Hello, my name is Tanya O'Sullivan and I'm an advanced practitioner occupational therapist in Neurorehab. I work in Hywel Dda University Health Board, and today I'm here to talk to you about the multimorbidity fatigue management pathway that we developed in Hywel Dda to meet the needs of a wide variety of patients in which fatigue can be a limiting factor. So I'll start off by briefly going through what fatigue is and why fatigue management is a relevant intervention for so many individuals with a long-term condition. Talk about the challenge of delivering fatigue management in a rural health setting and how we went about redesigning our services to meet a person's need, not their diagnosis. I will go through the fatigue management toolkit, which was key to develop equity in service provision, and talk about our education programme via MS Teams and how we adjusted to service improvements throughout the pandemic and delivering virtual groups. So, fatigue. Fatigue is defined as an overwhelming sense of tiredness, a lack of energy, and a feeling of exhaustion. Some of the quotes on this slide are from service users explaining the impact fatigue has on their lives. It's important to point out that it's not just physical, it's emotional, and it can impact on the whole self. But I'm sure many of you recognise this definition, particularly this year. We all get tired and we all feel fatigue. And for many of us, we can recover from fatigue with a good night's sleep. But for many with long-term conditions, there's a physiological cause to their fatigue, and it won't go away after a good night's sleep. They'll wake up the next day feeling the same. It's a persistent and overwhelming hidden symptom that can have a significant impact on their physical and mental well-being and prevents them from participating in chosen occupations and roles that are important to them, that make them who they are. As you can see, it's really prevalent as well across a range of conditions. A large number of people with brain injury, strokes, report fatigue having an impact on their life. Multiple sclerosis is significant at some course in that disease process that someone will report fatigue impacting, along with other neuromuscular conditions such as Parkinson's, Guillain-Barré, muscular dystrophy. 90% of cancer patients will experience fatigue at some point during their cancer journey. Over 70% of patients with a rheumatic disease reports disabling levels of fatigue, and a high number of patients with heart failure. And there's other patients missing from this slide, such as those with respiratory conditions, and of course, more recently, COVID-19. But as I said, it's a hidden symptom for many people with long-term conditions. And how do we treat it? How do we ask about it? Often it comes down to a health professional recognising the language patients are using. They may not say fatigue, they may talk about having brain fog, they may talk about that they can't do what they want to do during their day, that they start, intend to do things and then they just hit a wall. So it's about professionals using the right language, asking the right questions, trying to find out how someone is currently dealing with it. Are they dealing with it? And the occupational therapist may then go on to deliver fatigue management as an intervention. So fatigue management is a targeted intervention. It encompasses changing a person's knowledge, their attitude and behaviour. So none of these are easy to change, and therefore it requires a therapist with specialist knowledge and experience to deliver the intervention, so the person can go on and self-manage their fatigue and subsequently their condition better. Fatigue management is often best delivered in a group setting because you have the shared lived experience of others in the group and the peer support to help make the necessary changes in life. And I've just included some themes which are often included within a fatigue management programme. and was certainly part of our programme and part of the evidence base of interventions that should be included. But here's the challenge. How do therapists develop this specialist knowledge and skills within a rural setting? And that's why our service improvement came about, really. I was in a meeting with a group of occupational therapists that traditionally work in quite specialist areas, such as cancer, prehab, rheumatology, neurorehab, etc. So we were sharing good practice and we were sharing challenging practice, and we were looking at areas we had in common. And we were all delivering fatigue management to our patients in some form or another. But there was no consistent approach. Each of us had slightly different ways of delivering fatigue management, used slightly different resources. Some felt very confident in their knowledge and skills, but they were often using it, delivering it in isolation, clinical setting with their client group. And other OTs lacked confidence in this intervention. So we reflected that we weren't really being prudent on our delivery of services. We were basing our services around the diagnosis of a patient and not of their need to have an experienced therapist delivering fatigue management. And it also wasn't sustainable, and it wasn't in keeping with national and local drivers that encouraged us then to form a working group and set about doing some further service improvement. So the working group looked at the evidence base for fatigue management, and we developed a fatigue management pathway for all occupational therapists across the Hywel Dda footprint to follow, and more importantly, a toolbox of resources to use too. So this is our fatigue management pathway. So first, the pathway. This was to provide equity in the service. The aim was that wherever you lived in the health board, there was a consistent approach, and the pathway could be used by any occupational therapist within Hywel Dda or a support worker. And it supports them on how to intervene with an individual who reports fatigue. So the first part in yellow guides the OT to what screening tools they may use, the baseline measures that can be used to understand not just the impact of a person's fatigue, but that person's readiness to change. It then goes on to support the clinician's clinical reasoning, leading them either to choose A, that the person's actually satisfied or unlikely to make changes. So maybe you just provide them with some information about how to access the toolkit at a later point, if they so wish. It may be a modified approach, B, where an individual's fatigue is impacting just on a couple of domains, such as work, leisure, but they've really got the potential to self-manage with some input. So it's again providing the toolkit in its entirety and maybe doing 1 to 2 face sessions or virtual sessions now to support its implementation. Pathway D is actually the most sort of common route. This was suggested to be the most effective. It's also the most prudent. But in our group programme, we were innovative because we were bringing together patients from a variety of conditions. So within the groups, we're looking at it being multimorbidity, having people with MS, rheumatoid arthritis, cardiac problems, cancer, respiratory, stroke, etc. So that's pathway D, and the individual programme in pathway C is really where someone does need the whole programme, needs a full programme in it to be supported by a clinician, but they couldn't go to the group or they wouldn't be able to participate with the group, maybe because there's some cognitive deficits there or some severe sort of social phobias or anxieties. But this pathway, as I said, helps to guide the therapist into their clinical reasoning and which mode of intervention to deliver. And with that was the fatigue management toolkit. So it's currently just a PDF document used by therapists as a resource, but does provide a consistent approach across the health board. It's also, apologies. It also is a resource for the groups as well. So we tested this toolkit with a variety of patients before launching it across Hywel Dda. What I was trying to find then was the areas that the toolkit includes. So when I talked about what fatigue management was earlier, and it was around getting to know my fatigue, there's a chapter in there about rest, relaxation and sleep, about how to prioritise, plan, pace activities. Huge section as well about cognitive fatigue, because that's often missed out, and managing the psychological impact of fatigue. It covers things like being assertive as well. Not to mention exercise, which is very important, healthy living, and the ergonomics, the changes we can make in the environment and the way we do our tasks. So, as I said, the toolkit was trialled with a pilot group of patients before we made further adjustments and then launched it across Hywel Dda. So what next? Once we had our toolkit, we had our pathway, it was time to launch it and raise awareness with our OT colleagues. So we planned a series of workshops across the health board. And, you know, in fact, 2 of these workshops happened in person, but then lockdown hit and we had to stop it for a while. But we managed to get it online, and we then adapted to use MS Teams to deliver the training to many occupational therapists and OT support workers across Pembrokeshire and Ceredigion and Carmarthenshire, the 3 sort of localities of Hywel Dda. And actually using MS Teams enabled us to open up the training to far more people than we originally were planning to. So we were able to reach OTs in the acute settings as well as community settings, and not just within adults. We covered paediatrics, OTs and learning disabilities, and mental health. So we really did get that whole service approach. It also soon became apparent that COVID-19 and fatigue would be a sort of common symptom and potentially lasting symptom. So we included that within our training, and we developed some resources that could support our colleagues who were working with patients recovering from COVID-19. We created a leaflet and looked at pathways that could support patients and therapists. We included all of this in the staff programme and launched it on the Health Board's website. So we've now finished delivering the training to staff, and as you can see, the impact in terms of raising staff's awareness of fatigue and their knowledge of how to assess and deliver fatigue management has all increased by 2 points, just using a self-rating scale here. Confidence has improved by 4 points, and of course their awareness of this whole Hywel Dda approach within the OT service and the pathway and access into the groups has increased greatly. So we are now getting ready to deliver our first virtual multimorbidity fatigue management group online via MS Teams. So it'd be really interesting to evaluate how that goes and look at the outcomes of that versus the face-to-face group. We've also, within our training, the ethos was that it was a whole service approach. So all the OTs were invited really to be part of our working group and get feedback on using the toolkit across the health board. We also asked any OTs that were interested in co-facilitating the groups to sort of step forward. So if people wanted to develop their knowledge and skills further in delivering fatigue management or in terms of delivering therapeutic groups, they could co-facilitate the group and then go on to deliver the course themselves, maybe with the next OT that was interested. So it's kind of train the trainer model. Again, looking at building and sharing skills across the workforce and not just sort of holding them in specialist silos. So that's where we are, really. It's just myself delivering the presentation today, but I thought important to name check some of the other OTs involved in the working group. But thank you for your time. That's it.